warmest applause, we welcome Professor Omar Fawzy. He is from Amrita Medical Center in United Arab Emirates. Professor Omar Fawzy has become Fellow of the Royal College of Surgeons in Otolaryngology, Head and Neck Surgery since 1975. And he has been invited as VIP speaker at multiple international conferences since 1980. His main emphasis are rhinology, salivary gland surgery, endoscopic sinus surgery, snoring and sleep apnea surgery, endoscopic laryngeal surgery, and middle ear surgery. Today is a great honor for us to invite him, and we can listen from his over 20-year plasma coblation experience sharing. So let's welcome Professor Omar Fawzy. Welcome.
Thank you very much. Good afternoon. Here in Abu Dhabi, it's already 5 p.m. So really, I enjoyed the 3 talks which I heard, and very, very nice and scientific. I'll be more basic. Very difficult with tumors and these things. I will just talk about my experience with Coblation, because I started, I used, of course, the conventional, even I used sometime guillotine tonsillectomy, but in UK, but since 1993, I attended the American Academy, the 97 meeting in Minneapolis, and there was a nice Italian doctor who introduced bipolar tonsillectomy by bipolar forceps. The first forceps, please. I want to show you this, the first slide. You can put the first slide. You can hear me, or I cannot hear her. Yes.
Yes, you can be.
Can you put the, the bipolar? Can you hear me?
Yes.
Yeah, but and the slide is, I think it's with Joanna. Joanna?
Joanna, who's Joanna?
Yeah, because
Joanna.
She did not send to me. I think. And Lina was now calling Joanna.
Yeah, yes. Next one. You have slides? She sent, yes. You see the slides? You can see the slides?
Yeah, yes, we can see this slide.
Can go, yes. This is what I meant by bipolar tonsillectomy forceps. This is a simple bipolar forceps, and we use it for the dissection. It have 2 it's the same shape like this, bionic shape, but it have on one side a small tube which dribbling saline inside the wound to reduce the thermal effects of the bipolar coagulation, and on the other side there is a small suction tube. The principle is exactly like what is in the Coblation. The idea is to use a heat, but reduce the thermal heat, but it doesn't have plasma, of course, because this is a simple bipolar. The bipolar forceps have 2 functions. I mean, you can just keep the plates away so you can coagulate, and you can get them together so you can cut. In 2001, I first saw the first implication of the Coblation in ENT. It was published in the British Medical Journal. At that time, I tried to contact, but I couldn't get it till 2004. 2004, I had it in Abu Dhabi. I have the first Coblation in Abu Dhabi, and I was using it. The recommendation in the beginning for the Coblation that it was easy to use it under local anesthesia. I was lucky enough that I was working at that time in a center, mainly working with the dental, the dental, it's a dental center, so they have what you call it gas anesthesia or giggle anesthesia or laughing and gas, this is which they give the kids so they can operate in their mouths easy. I used the coplator for quite a bit of time locally for reduction of turbinates, UPP, reduction of tonsils, not removal of tonsils. And, after that, we start using it under general anesthesia. The handles of the coplators, of course, as most of, this is the machine itself, how it works, all of you, that this is coming by the saline, which produce the plasma, and the plasma is a very important addition to the classical, bipolar cautery, because it reduces the pain and make, the wound, easy for the child or for the adult to swallow. And next slide, the handles, of course, the nasal probes I used, and I used the one for the tonsillectomy. At that time, we started doing tonsillotomy, which is reduction of tonsil, removal of the tissues, but keeping the capsule outside. This procedure is much less pain post-operatively, and the convalescence of the patient is very, very much less than the conventional tonsillectomy. Of course, I had so many, cases. I don't know. I don't count, the number of tonsils, because we are continuously using tonsils, the coblation for tonsils and the turbinates. I am doing endoscopic sinus surgery, not in, I don't do much of the larynx, and I don't do much of nasopharynx and this area tumors. I'm not included in the oncology section, in the oncology sector at all of ENT. I am mainly doing the conventional tonsil adenoids. The handles is, of course, as you know, you can first, this is the turbinate reduction. The turbinate reduction, you have a technique for it. You have to start by coagulating, then you introduce the probe inside to the end. The beauty of this handle that it can reach the far end of the inferior turbinate, which is usually very difficult in conventional surgery. If you do cautery, you cannot reach this very far end, which is called ballooned posterior end of inferior turbinate. And this is the patient when you can look with the endoscope in the anterior part, you find it's very nice, capacious, but the patient is blocked. Then you go further, you find that the posterior part of the inferior turbinate is ballooned. This probe can do this. This probe have, of course, you have, I'm just talking classically and basically for those who does not have much experience with coplator. When you put it inside, you don't just push it, because it will break the inferior turbinate, and the inferior turbinate will bleed, and will bleed too much. You know all of you, that the inferior turbinate is very fragile, and when it bleeds, it does not stop. So it's better to use cautery, then put your probe to the distance which you want, which is most probably like you have to put it all inside to reach the posterior end, and then do the ablation. And then in going out as well, before you just leave the mucous membrane, you have to cauterize again to stop the bleeding. The bleeding is minimal, but I have to tell you that you have to tell the patient, frankly, that this is not going to be everlasting procedure. No, the patient will realize that this is already based on his nasal allergy, and the hypertrophy is a secondary to nasal allergy, so it will come back. So the patient has to expect this. Two things that he have to expect: that after the surgery, he will be very fine first day. Second and third day, he will have much more block. Then after that, he will have a relief, but this relief is not going to be last. He can expect that to do another sitting or something. It is a very simple procedure. This can be done in the outpatient clinic. It does not take more than 5-10 minutes. Then we have this, of course, I cannot talk about this. This is the submucosal reduction and the tongue reduction. This has been already covered very well by Dr. Burgess, and I am not practicing this. If the patient needs something in the base of the tongue, I refer him to somebody else. Oromaxillary surgeons are here. Are you doing this? I'm not included in this. But for sleep apnea, tonsil adenoids for adults and the tonsil adenoids for children. Practically now, most of the cases, I do tonsillotomy, reduction of tonsils. I remove the contents of the tonsil and leave the capsule. This, with my experience for follow-up, is much, much better than tonsillectomy, because most of these patients at an elderly age, they get reflux. And if you remove the whole tonsils, you expose a big pharynx for him, and you will have more trouble with reflux than if you do reduction of tonsils. And reduction of tonsils, usually you can do it thoroughly till you completely eradicate the tissues and the lymphoid tissue and keep the capsule. Number one, it reduces the post-operative pain very much, very much, and it makes the convalescence of the patient very quick due to the plasma formation. This plasma layer, which is covering the site of the surgery, make the patient much easier to go back immediately to normal diet. No need for fluids and ice creams and these things for a long time. The coplator, because you can easily handle it and you can move around, and there is a lot of flexibility around the tonsil to remove it and to remove the lingual tail, which was neglected in many cases previously in this section. So this is regarding the pain. Of course, the bleeding, you can say primary bleeding, this depends on you first when you are pre-selecting the patient and preparing the patient in the first place. The reactionary bleeding is very much less than the conventional techniques of tonsillectomy. The post-operative the secondary bleeding, which happens after 6 days due to infection, is very easy controlled by maybe 1 or 2 shots of IV antibiotic and something like the dicinone, which improve the stabilization of the platelets. But the post-operative is much easy. Laryngeal, of course, you have covered it, both the three. I don't need to repeat on it, but it's very good for Ranks edema. It's very nice for this is what I'm doing. I still saying I'm not oncologist. I'm not doing much of tumors and these things and the larynx, but for this, it's very, very nice and effective. And practically there's no bleeding, there is no pain. And the pain which we experienced it before in uvulopalatopharyngeoplasty and laryngeal surgery with the laser is absolutely now free from pain, because the laser used to do a very deep burn, and you cannot control the burn, the depth of burn. You can control the power, yes, but the depth of burn. I used diode laser for many years for laryngeal surgery, and I'm not definitely the coplator is much better, and the pain which comes after is very minimal. If there is pain.
هذا مرة واحدة في اليوم، شراب هذا 6 مرات، هذا مرة بالليل، زين، وبخار 5
Who's that? Somebody is on the line. But anyhow, this is the submucosal channeling. As I told you, this is the last part of the inferior turbinate, the most important part when you are going to do this channeling of the inferior turbinate. These are the 2 things which I told you in the beginning that I use them with my bipolar forceps. Is the irrigation, reduce the heat effect, and this is the advantage again over the laser, and the suction, which keep you the field clear and easy, and you can see the bleeding points and you can control it. There is some more actually things to say about this you know, this technique of, it's not for everybody. I don't recommend if there's some juniors, doctors are watching us, they should be careful if they want to do what Professor Burgess and Professor Hung and Professor Lee have done, because these are something which need a lot of training. It's not an easy thing to do it. No, you have to have a good training for it, so you get the best of the machine itself and the best of the technique. It's not for anybody to come and remove a tumor. No, this is not easy at all for the beginners. The beginners has to start on something little like this: tonsils, adenoids, reduction of turbinates. There is a new probe which I saw, and it's done by BONNS, actually. This is the good thing about it. This new probe is called MAX. The MAX have a very good thing. This is the shape of the MAX. The MAX have a very good thing. This was not used before. I never used it in any other. I used, of course, Smith and Nephew beginning the handles, but this is a great because it does not get blocked. Because you see the hole is quite big, but in general, you know, every one of you knows that this is a non-touch technique. I mean, you're not going to keep, you know, getting the tissues. No, this MAX is just introduced in Abu Dhabi very recently by the company, and it is very nice and very successful and very easy to do it. So I thank you, BONNS. When the COVID is over, I would come and visit you, inshallah, to see your place. And we are using this with great comfort. Your handles are very good. You know, I state for you, and we now using this, the only handles we are using in our private hospital for our ENT conventional surgery. Okay, thank you.
Thank you. Thank you.